Good afternoon, everyone. Welcome to the At Research webinar for today. And it is such a pleasure to have so many of you join us today from right around Australia. And of course, it is a great pleasure to be sharing more of the wonderful health services research that's happening in regional Victoria. So my name is Heather Cameron, and I'm the Program Manager for the Revitalise Project's Regional Research Teaching Hub, and we, of course, are the hosts of the At Research website. On behalf of the Regional Research Teaching Hub and everyone here today, I would like to begin by acknowledging the traditional owners of country throughout Australia, and I recognise their continuing connections to lands, waters and communities. I pay our respects to Aboriginal and Torres Strait Islander cultures and to elders past and present. And I extend a very warm welcome to any Aboriginal and Torres Strait Islander people who are joining us today or who are perhaps watching the recording of this on YouTube. So just some very brief housekeeping before we start. There will be an opportunity to ask questions to our presenters. So please use the Q&A button at the bottom of your screen, and you're welcome to use that throughout the webinar. There will be an evaluation circulated post-webinar, and I'll also show you a QR code at the end. So I really encourage you to provide feedback to us because it helps us in our planning. And of course, there will be access to the recording of this webinar via the At Research website, so I invite you to share it with colleagues. So without further ado, I'm now going to hand over to Professor Mai Krishnasamy, who's one of the co-leads of our team, and she's going to facilitate today's webinar for us. Thank you, Mai.
Thanks very much, Heather, and a very warm welcome to all of you who've joined this afternoon to hear about the PANConnect trial. As Heather says, my name is Mai Krishnasamy, Professor of Cancer Nursing at the University of Melbourne, and it's my very real pleasure to be here. And I'd like to acknowledge the welcome to country that Heather, or welcome and acknowledgement of traditional owners that Heather has shared with us. So my real pleasure this afternoon is to be able to introduce our two speakers, two very good colleagues of mine, who are really driving the PANConnect trial that was funded by the MRFF. I'm not going to say much because Maeve and Lisa will talk to that, but just to briefly sort of put some context, that this is a study that came about out of a realisation that there is across Australia a real lack of equity of access to specialist cancer nurses, particularly for people who have rare or less common cancers or cancers that have poorer outcomes, and especially so for people who live in regional rural areas. And so the study, the basis of the study is thinking, is there a different way that we can package and deliver care to make sure that people who are experiencing challenging cancer diagnoses, like a diagnosis of pancreatic cancer, have equal access to a specialist cancer nurse? And so I'm just going to introduce Maeve and Lisa to you and then hand over for you to hear more about the work. I'm going to read this because there's quite a lot to say about both of them. So Dr. Maeve Cullinan has a background in molecular microbiology, and she is the project manager of the PANConnect trial. She has previously led a number of statewide maternity service evaluations, including an evaluation of a maternity education programme delivered to regional and rural maternity services and those providers across Victoria. She's an interest in breastfeeding research and is involved in a study exploring GPs' knowledge and use of the therapeutic guidelines for the treatment of breastfeeding conditions. And it was a huge boost to us the day that Maeve applied to be the programme manager for the PANConnect trial, and delighted that Maeve will have an opportunity to talk about that work today. And then the second real driver and powerhouse behind this trial is Lisa Brady, who is a clinical cancer nurse consultant with almost 30 years of experience of working within the cancer field. Over the course of her career, Lisa's held several positions in advanced clinical nursing roles. She has expertise across symptom management, complex symptom management, telehealth, and research, and so brings that richness of experience to the PANConnect trial. She's managed several complex, large projects with focus on improving consumers, both patients and family members and carers' experiences of cancer services and the care that they received throughout their cancer diagnosis. So it's my very real pleasure now to invite Maeve and Lisa to talk to you about the PANConnect trial. Thank you.
Hi, everyone. Thanks, Mai, for that introduction. I'm going to share my screen now and we'll get started on the talk. Okay. So I hope everyone can see what I'm looking at. It's not... Can everyone... I guess we can't tell. Well, I'll just keep going. Okay.
I just think that you need to pop it into a slideshow.
Oh, so you can see, Heather. Okay.
Yeah. That's right.
Then maybe I'll just do this.
You click from beginning, does that work?
No. I'm going to stop sharing and I'll start again.
Okay.
Maybe I'll just, because it's this one, right? Yeah.
This is the joy of working virtually, isn't it?
That better?
Oh, perfect. Wonderful. Thanks,
Okay, good.
Maeve.
Okay, good. Okay, so thanks, Mai, for that introduction. I hope everyone can hear us okay. So we are going to talk to you today about the PANConnect intervention. So PANConnect is a centralised nurse-led telehealth service to increase equity of access to specialist cancer nurses. And thanks, Mai, for explaining it so well. As Mai said, my name is Maeve and I'm the project manager for PANConnect, and Lisa beside me is a cancer nurse consultant and is the specialist cancer nurse involved in delivering the PANConnect intervention that we're going to talk to you about. So you'll hear from both of us today. I'd also like to acknowledge the traditional owners of the land on which we work and also pay my respects to elders past and present before we begin this talk. This slide shows the project team. So there's a lot of people obviously involved in the PANConnect program of research. Mai Krishnasamy is the chief, the coordinating principal investigator. And we have an implementation science lead, Dr. Lisa Guccione. And I'll also acknowledge the researchers at Bendigo Health. So Dr. Rob Bloom is the site principal investigator at Bendigo Health, which is a partner service in this program of research. I'm sure everyone is aware of these data. So pancreatic cancer has one of the lowest survival rates of all cancer types worldwide, with a death to incidence ratio approaching 1. So nearly the same number of people die from pancreatic cancer as are diagnosed with the disease. So to give you an example, in around 1,000 Victorians each year are diagnosed with pancreatic cancer, and we see almost the same number of deaths. It is the 10th it was the 10th most commonly diagnosed cancer in 2021, but currently it's the 3rd leading cause of death in the state, as we can see here, and it does have a high burden of disease. So this includes pain, loss of appetite, fatigue, and also depression and anxiety. So this figure shows the health inequity in rural and regional Victoria. And again, I'm sure everyone is aware of this. So what you're looking at here is the 5-year relative survival from the most common cancers. So we can see here that rural and regional populations show reduced survival across the board for all malignant tumours compared to their metropolitan counterparts. And further, you can see that for pancreatic cancer patients, the first thing to note is that they have the lowest survival, but we also see this inequity of access. So we see patients in major cities showing increased survival compared to those in regional Victoria. So from the research, we know that having access to a specialist cancer nurse improves experiences of care provision and outcomes, including quality of life and even survival. However, because there are relatively low numbers of pancreatic cancer diagnoses in Australia each year, it is a challenge for services, particularly these smaller rural and regional services, to have access to a dedicated specialist cancer nurse available to these patients. So we see that in Victoria, specialist cancer nurses for pancreatic cancer patients are primarily based in metropolitan centres. So this, again, we see this inequity of access for rural and regional patients. So with that in mind, the PANConnect programme of research was designed to address the health inequity that exists for pancreatic cancer patients. So this talk has 3 parts, 3 components. So phase 1 of the PANConnect programme of research was the co-design of the PANConnect service. And we will share some information on this project or on this process and what the PANConnect service looks like in reality with you. We'll then speak about phase 2 of this programme of research, and this was a feasibility study that we conducted at Bendigo Health, and this was conducted to assess the implementability of PANConnect at this service and refine the model if it needed refining before we embarked on stage 3 or phase 3 of this programme of research, which is a multi-site randomised trial assessing the impact of PANConnect on pain and symptom burden among pancreatic cancer patients. So we're going to talk about these 3 phases in this talk, just to give you a flavour of what the programme of research looks like. So first, in terms of the co-design process, so in terms of what the model looks like, PANConnect was co-designed with consumers who had a lived experience of pancreatic cancer, healthcare professionals and the research team through a number of focus groups. The model was designed in partnership with Bendigo Health, and the service has been a partner right from the get-go. So in the next few slides, Lisa is going to talk to you about the essential components of PANConnect that came out of that co-design process.
Thanks. So here are some of the themes, the main themes that come out of the process. And as Maeve has already mentioned, it was done in the form of focus groups. So firstly, the attendees wanted early and timely assessment of their symptoms. So due to the often high level of symptom burden that we know that patients with pancreatic cancer can experience, the decision was made for weekly telehealth consultations. The next was decided that there needed to be appropriate symptom management and escalation pathways, and that's really for the nurse. So, so we're following a pathway to, instead of ourselves deciding when a patient needs help and so on. So fortunately, we were given permission to use what are known as clinical management pathways, and I will talk to you a bit more about those pathways in the next few slides. But importantly, as I just said, these pathways act as a guideline for the nurse to inform practice and escalate care appropriately. Oh, no, sorry. I can't get it to, sorry. Oh, thanks, Maeve. Sorry about that. The next thing is consumers wanted information from credible sources, which goes without saying, so Cancer Council and Everq. They also wanted referrals to supportive care services if they were needed, and we'll talk a bit more about how that will work, how that works. And importantly, the consumers and the health professionals wanted outcomes from the pancreatic consultation to be reported back to the treating team so that everyone's on the same page with their care. So what does this PANConnect service look like? To start with, the patient uses an 8-item PROM called the Bacardi, which is specific for pancreatic cancer, and I'll show you that in the next slide. They use this to report their symptoms. Then they receive this the day before the scheduled telehealth consultation, and we send that via a text message, and it takes them about 30 seconds to fill out on their phone. The next day, they have the telehealth consultation with the nurse, where the symptoms are assessed and graded using these clinical management pathways, the CMPs. So depending on the severity of the symptoms, there is an agreed plan put in place with the patient. So for mild symptoms, this is usually in form of just information provision only, and this could be just a discussion while we're on the phone with them, or sometimes it's written information that they would like to be sent, and that's just done via email. But for the more moderate and severe symptoms, there may need to be a referral put in place, or they may need to be reviewed by their treating team within a specific time frame. And in these instances, there is always communication back to the participants' treating team via the clinician report to inform them of the outcomes of the consultations. Also, if they're extremely severe, if it's something extremely severe, then that will also be followed up with a phone call to the treating clinician. So this is the Bacardi. As you can see, it's very simple, short, and obviously all these issues are for pancreatic patients. Then I'll just tell you a little bit more about the clinical management pathways, the CMPs. So we're fortunate enough to be given permission to use the CMPs. They were developed as part of another project called the Pro-Patient Trial at Monash University. And that trial was a telehealth nurse-led model designed to improve the quality of life with people with upper GI cancer. And I was also a specialist nurse on this trial as well. So the CMPs were developed with about 50 multidisciplinary team clinicians across Victoria. There was a total of 19 developed for the trial. And so what we've decided to do is give you an example of the CMP for pain. And as I already mentioned earlier, these pathways act as a guideline for the nurse to inform practice and escalate care appropriately. Another important thing to say as well is that this offers a standardised approach to the assessment of each symptom. So regardless of who the nurse is in this role, the assessment will be the same. So the first part of the symptom assessment uses some questions adapted from the Fraser Health Authority in Canada. And this is to get a much more in-depth understanding of the symptom, i.e., has this pain changed? Is it a new pain? Can you describe your pain, etc.? The nurse then grades the symptoms reported using the CTCAE grading system of mild, moderate and severe. And we've also incorporated a traffic light system to these grades, as you can see. So this grading informs what advice and care is delivered by the nurse. For example, mild pain means information provision only, whereas moderate and severe pain grading means that there is an escalation policy around the timeframes for that participant to be reviewed by their medical professional at their treating health service. This is an example of the clinician report following the telehealth consultation. And this is, as I said before, it's delivered to the participant's treating team when the patient reports a new or ongoing symptom that requires attention. So what it does, it highlights the symptom reported, the severity rating provided by that patient, and then the PANConnect nurse recommendations and agreed plan of action for each reported symptom. So we make sure the patient is on board, especially if we're doing referrals or they need to be get to be seen back in by the treating team in a time frame, so everyone is aware of what's happening and the patients agreed to that to be done. So accordingly, this clinician report really facilitates standardised documentation and ongoing consistent communication with the participants' treating team. And this works better than having access to the clinical notes and writing notes directly into the medical records. This stands out, so anyone that comes across the clinician report throughout all the health services involved in our study is aware that this is communication from this trial.
Okay, back to me. Thanks, Lisa. Okay, so when we knew what the PANConnect model looked like in practice, the next step was to assess how feasible and implementable it was. And we did this at Bendigo Health. So this is part 2 or phase 2 of the PANConnect program of research. So I'll share some data to come from this feasibility study over the next few slides. Okay, so the PANConnect feasibility study was funded by the Western and Central Melbourne Integrated Cancer Service, or WICMIX. We used a mixed methods approach for this study. So that means we collected both qualitative and quantitative data for the study. Our aim was to recruit no more than 10 patients with pancreatic ductal adenocarcinoma and provide them with PANConnect weekly telehealth consultations over 12 weeks. So 12 telehealth consultations in total. We also invited carers and healthcare professionals providing care to patients recruited to the study to take part. In terms of the data that we collected data on how acceptable the model was to patients and carers, whether they thought the model was feasible, whether they thought PANConnect was delivered as intended. And we used 2 implementation science frameworks to inform the data collection tools that we use. And these are the theoretical framework of acceptability, or the TFA, and the theoretical domains framework, or the TDF. This looks like a really complicated slide. I hope everyone can read it. I'm just highlighting, this is a flow chart for the study. And I just want to highlight the fact that patients, once they were recruited, they completed assessments at baseline. So these incorporated measures of pain and symptom burden, looked at emotional health, financial toxicity, and then they had their 12 telehealth consultations over the 12 weeks. And then at the end, they completed these same measures again. During their participation in the study, after they had at least 4 telehealth consultations with Lisa, we asked patients to complete a short survey and an interview, which were informed, like I said, by these 2 implementation science frameworks, the TFA and the TDF. And we conducted these implementability assessments to really explore their views on the model of care. So that's what I'm going to present in this presentation. We're going to show some data from the short survey and the interview in the next few slides. In terms of the patient population that we recruited to this feasibility study, we recruited 9 patients in total. Most were female, most were partnered, and the mean age, as you would expect, was around 75 years of age. Again, this looks like it's a complicated slide, so I'm just going to talk through it. This slide looks at fidelity to the PANConnect intervention. So the blue boxes here show the PROM, the patient reported outcome measure completion, and the green boxes indicate the weekly telehealth consultations that were completed by each participant. So we see each of the participants down here, 1001 down to 1009. So we discussed as a team about what fidelity looks like. Was it fidelity to PROM completion or completion of the telehealth consultations? And given the telehealth consultations happen with or without PROM completion, we looked at completion of these telehealth conversations as a measure of fidelity. So that's what you're looking at here. So we can see here that 1 participant unfortunately passed away during their participation in the study, and another participant had a holiday planned. So they received telehealth consultations up until the time of their holiday. But what this slide really shows is that most participants received all 12 telehealth consultations. One participant here missed one consultation, but they did complete their PROM, so Lisa was able to look through their responses anyway. Another participant here couldn't complete their PROM for 1 week, but still had a telehealth consultation. One participant, 1008, we can see here, completed 5 PROMs only, but received all of their 12 scheduled telehealth consultations. This participant commented that they would really like to see an open-ended text option included with the patient-reported outcome measure with the PROMs that they complete, because they noted that the PACADI that we use may not cover all of the symptoms that patients may be experiencing. So we have taken that on board for the trial that we are about to conduct, and we have subsequently included an open-ended section at the end of the PACADI PROMs for this multi-site PANConnect randomized trial that is phase 3 of this research program. As I mentioned in the study's flowchart or the schema slide that I showed, the implementability of PANConnect at Bendigo Health was assessed via interview and survey. So the survey that patient participants conducted incorporated one of those implementation science frameworks called the theoretical framework of acceptability. And this was made up of a number, 8 in total, 5-point Likert type questions and statements about PANConnect. So it was quite easy to complete. The interview was informed by the TFA and also the theoretical domains framework. So our intention was to conduct the survey and interview implementability assessments after at least 4 weeks of exposure to PANConnect. So this table shows when we actually completed these measures, and we can see that in reality they were conducted around 6 weeks after exposure to the model, which is not a bad thing because, you know, patient participants had more exposure to PANConnect. So this allows for richer data to be collected, especially via interview. What you're looking at here are survey data informed by one of those implementation science frameworks. So as you can see, everyone found that the model was acceptable and feasible. Patients reported that it didn't take much effort at all to be part of PANConnect, and they were all confident in taking part in PANConnect. And this is really important for this demographic, given that they're slightly older, they need to be confident in using technology to take part in the telehealth consultations. And this is one reason why we decided to deliver PANConnect by telephone, because we thought it would be easier for this demographic to be able to take part in the telehealth consultations by telephone. So from the last slide, we could see that patients found PANConnect acceptable and feasible, and they were confident interacting with the intervention. We also asked patients whether they thought the model had the potential to improve pain or other symptoms, and these are the data that you can see on this slide. So 6 patients agreed or strongly agreed that the PANConnect model of care had the potential to improve any symptoms or pain that they had related to their cancer. Interestingly, 2 participants did not have an opinion on this, and they mentioned during their interview that this was due to the fact that they had not experienced many symptoms up to that time point. So we think that several of these survey questions may actually be more applicable once participants have had their full exposure to PANConnect. So what we have done for the randomized trial that we, or phase 3 of this program of research, is to include the implementability survey in the 12-week patient outcome measures for the PANConnect multi-site randomized trial. We're continuing to analyze patient care and healthcare professional interview data But I'll share some quotes with you from patients and carers in the next few slides. These are some of the quotes to come through from the interviews with patients and their carers. This slide talks to the safety and quality of care provision from PANConnect. So one thing I do want to stress is that even though patients were encouraged to contact their treating service if they encounter symptoms or side effects of treatment, we found during this study that several were actually quite reluctant to do this in some cases. Sometimes they didn't know who the appropriate contact would be, for example. So this is where PANConnect can help. So they can help patients navigate the pathway of cancer care. And some of these quotes, I think, highlight that. So the first quote is from a patient who had pneumonia, which was picked up through the telehealth consultations. So Lisa encouraged the participant to present to emergency where the pneumonia was subsequently diagnosed. And this participant had chest complications over a number of weeks. The second quote, and I'll let you read through it now, is from a patient who developed a fever post-chemo, and they presented to emergency at another rural hospital where bloods were taken. The patient was discharged before their blood results were known, and then they subsequently called Lisa, who facilitated them to call the Symptom Urgent Review Clinic, or CIRC, at Bendigo Health. So with a potential oncological emergency such as this, Lisa also followed up with the CIRC clinic and with the patient to make sure that they were seen by the service, which they were. So consequently, this patient was neutropenic and chemo was withheld for 2 weeks. The third quote on this slide is from a patient who was in a pain crisis and was reluctant to contact their treating clinician. Lisa could facilitate PALCare intervention, and this patient was then admitted to PALCare for 5 days to address their pain. So these quotes speak to the power of PANConnect in advocating for the patient and helping the patient navigate the health system and getting them the help when they need it. So the next few quotes here speak to the peace of mind that PANConnect offered and the fact that the PANConnect nurse had time to listen to patients and their carers. The first quote, and you can read through it, is from a carer, and they mentioned 3 important factors that they valued about PANConnect. So the first is that they're having access to, you know, the model of care offered peace of mind because you're having access to a specialist cancer nurse. The second plus was the telehealth model. They found it very convenient not to travel to a particular venue. And then the third plus was the manner of the PANConnect nurse, which they thought obviously was very important. So it's also worth mentioning that this carer lived apart from the patient. So the telehealth consultations were 3-way phone calls with the PANConnect nurse, the carer, and the patient and their partner. And this worked very well. And the next quote is from a patient who says, if you get into trouble, you ring her, she's got the answers. If she doesn't have the answers, she finds them out. So they found that very helpful, and that was, gave them peace of mind. In terms of the time forwarded by the PANConnect intervention, one carer mentions that they valued the fact that it was a minimum of weekly contact. And if you had, you could contact any time in between if you needed advice or help. And the last quote is from a patient, and it highlights the importance of being listened to, which the PANConnect service offers. So you can read through that quote also. So what does all of this show? From the data that we've analysed so far, we can see that PANConnect was implemented well at Bendigo Health. There was very good fidelity to the intervention. Most participants completed all of their 12 telehealth consultations. Patients found it acceptable and feasible. We are continuing to analyse the interview data from patients, carers and from healthcare professionals, but we have made some small refinements to the model ahead of our multi-site randomised trial, assessing whether PANConnect can help with pain and symptom management for pancreatic cancer patients. So these include having that open-ended section at the end of the proms and including the implementability survey with the 12-week outcome measures. So I'll spend the last few minutes of this talk talking about the third step in the PANConnect program of research, and that's this multi-site randomized trial. So this is something that we're starting to embark on now. The primary objective of the PANConnect multi-site randomized trial is to evaluate the effectiveness of the PANConnect intervention plus usual care in reducing pain and symptom burden compared to usual care alone. That's the primary objective. We have a number of secondary objectives, and these are listed here. I'll just run through them. So we're assessing the effectiveness of PANConnect on addressing unmet needs and reducing patient and carer emotional distress. We are including measures of financial well-being and toxicity. We also have the health economist who is conducting an economics evaluation, so looking at healthcare resource use and how cost effective the intervention is. And we'll also look at the implementability of PANConnect at each of the trial sites again. So it's the same as what we did for the feasibility study. We will also aim to develop an implementation package which will enable PANConnect to be scaled across sites or applied to other cancers if the intervention proves to be effective. So in terms of the randomized trial, MAI has received MRFF funding to conduct the trial over 3 years. Like I said, it's a multi-site trial, so we are conducting it at a number of metropolitan and regional health services across Victoria. There are 7 in total. Recruitment is anticipated to take around 18 months, and we're hoping to recruit 146 participants to the trial. So I've listed the broad inclusion criteria here for you to see. So patients obviously need to have a confirmed diagnosis of pancreatic adenocarcinoma. It can be at any stage, independent of resectability, and patients would need to have at least 3 months life expectancy for them to be able to complete the 12 weeks of telehealth consultations. So at the moment, we've commenced the trial at the 2 regional services, so Bendigo Health and Border Medical Oncology, and we will commence at some metropolitan services shortly once governance approval comes through. So hopefully Lisa and I will be back here presenting some results from the PANConnect randomized trial to you in the not too distant future. Watch this space. That's it from me. Before I finish, I need to acknowledge the funders, so WICMIX and the MRFF. Bendigo Health, like I said, have been a partner the whole way through. It's been amazing working with them, getting the feasibility study up and running there, and now the trial. So we're very excited to be working with Bendigo Health. And I've also listed the other sites that are involved in the PANConnect trial. Some of them are coming on board now, and hopefully the rest will come on board in 2025. And here are some of the references that I used during this talk. Thanks so much. I think I'll stop sharing now, and then we'll have time for questions.
Thank you both very much for going through that programme of work. Really great to hear about the work. There are, at the moment, no questions in the Q&A. I would just like to ask you one thing, well, a couple of things, but, you know, we're moving into the randomised control trial. And, you know, as we've talked about, our purpose here with this work is to really address issues of inequity of access, particularly for people in regional rural areas. But of course, in our RCT, we've got 5 metro sites at the moment and 2 regional sites. So can you talk a bit about the rationale behind that, and why that's going to allow us still to address this important issue around improving opportunity for regional rural cancer patients?
Yeah, sure.
You go for it.
Okay, thanks, Mai. Very true. Yes, we do have 5 metro services, and I think so. I guess it's a number of reasons, isn't it? Really. So the first is in practical terms. So, many patients from the regions are presented a lot of the time, especially if they have surgery in Melbourne. They're presented at a multidisciplinary team meeting at metropolitan Melbourne sites, and then they go back to the regions, for example, for chemo. So our intention and our hope is to pick those patients up then. So they will be identified at the metro site, but and then go back to the region. So we're hoping we'll still pick up the regional patients in that way.
Yeah, thank you. So it's that opportunity to not lose those really important regional patients as they go back from the metro sites to have their care appropriately close to home, which is, of course, what most people want. So thank you for explaining that.
Yeah.
For people out there in the audience, some of you I may have the pleasure of knowing, I will keep talking. So please, if you have questions, pop them in. But otherwise, I think one of the things for me, and, you know, the 3 of us have talked a lot about this, is from your perspective so far, being so close to this work, what are some of the most striking things, do you think, that you've noticed about the opportunity of this kind of model, but also, you know, whether you feel there are any barriers or limitations to it that we need to be, you know, thinking about or, you know, taking on board as we work through?
Well, from a nursing point of view, it's a very different telehealth than being on the front line, delivering someone their chemotherapy in a chemo day unit or on a ward and someone's really unwell. And I think you kind of have to deliver your approach and your and chat to the patient like you're sitting in their lounge room with them having a cup of tea. And I think that I feel very privileged in this role that I get this opportunity, because I'm not thinking, have they got all their discharge meds? Have they got this? Is, you know, you forget about when someone's at home. I feel when you on the front line, you just, the next patient's coming through, or you've got to go and do this. So it's a very different mindset, and the patients have commented how they feel. Obviously this role, it's busy, but they don't see that you're busy running around, so they have time and they feel comfortable in their home to actually ask questions and to have that time with the proms to be able to think about, actually, what am I experiencing and what can I get help for? Yeah, I think they also seem to, this is my experience anyway, they seem a lot more comfortable to ask a lot more well, they're not difficult. They're pressing questions that someone, obviously, a lot of these patients are palliative. And there's a lot of questions about death and dying, which is great to be able to explain it and, you know, get them the help that they need and being able to listen to them while they're so relaxed. And as I was once told many years ago when I was a junior nurse and I worked on a palliative care unit, someone said, if a patient asks a really hard question that you really don't want to answer, you need to answer it and you need to be honest, because this might be the only time that they ever ask someone this question. And it stuck with me forever. And as I say, my many years of experience, these are the questions I'm getting now while I'm chatting to them over the phone. So,
yeah.
And I think they're anonymous as well, so they don't know, they don't want video. They're very, very happy to answer it while they're driving around and living their life, which is wonderful. And I think that they're a bit anonymous, even though they build up the most amazing rapport in those weeks. But I think that helps the situation as well for patients to really tell you what's happening.
Yeah, and that actually came out in the interviews. some of the patient participants made mention of the fact that the intervention is delivered by telephone actually means that they can be more honest, and it allows them to kind of open up a bit more. And the fact that I mean, so one of the participants during the interview mentioned the fact that they were out playing mini golf during one of the telehealth consultations. So you know, it's you still could live your life, but take part in these telehealth consultations at the same time. So it was a very flexible model of care that PANConnect has afforded these participants.
Yeah, thank you. And there's some questions coming through. So thank you, Craig. So 2 questions here from Craig. So congrats on the robust conduct of the pilot. And I think this is a really important point, but the process that we've outlined and we've talked about may seem daunting for some people, particularly for people in the audience who are here to learn about research. And I think, you know, that's a really important point. I'll hand over to Maeve and Lisa at the moment, but I think for me, Craig, in response to that is, you know, I think it talks to the fact that changing models of care needs to be a slow, considered process. I think as health services and clinicians, often we want to answer things quickly. We wouldn't do that with new drugs coming online. And I think, you know, one of the conversations we have all the time is to do this kind of co-design work well, to take the time to hear what people want, both clinicians and patients and their family members, takes time. And so it is a complex process, but there's lots of help out there. And of course, Act Research is an obvious place to go in terms of the website, that has all of the tools and resources around how would I set up a co-design study? What are the kinds of approaches I need to take? Do I need to pay consumers for their time? How do I do that work well? How do I bring consumers and clinicians together? All of those things are there. And then to the second part of your question, Craig, you know, did we find it hard to use the implementation science tools? And I'll hand over to Maeve and Lisa now on the protocol stuff. You know, they are complex, some of the implementation science tools, but again, everything is available, ways of describing what those different frameworks and implementation science theories are. It's all there at research at your fingertips. But also, you know, it's about joining communities of people who've had the opportunity to use those and can offer some advice. But Maeve and Lisa, really interested, you know, we've used the theoretical framework of acceptability, the theoretical domains framework. From your perspectives, have they been challenging and difficult to use?
I think, given, I'll speak for both of us,
Yes.
maybe the fact that neither of us are implementation scientists, and some of the time they can be quite theoretical, I suppose. And we were very lucky that we do have Lisa Guccione, who's an implementation scientist. But when you do break them down to a practical level, I mean, they do offer help with some of the practical questions that you ask. So they are helpful in that respect. But I think having an implementation scientist on board is certainly was certainly a help with the feasibility study. Yeah.
And I think, you know, for those people online who are thinking about some of these frameworks, the application of them sometimes is quite straightforward, and the TFA, the theoretical framework of acceptability, is a great example. There's a questionnaire that goes with it that allows you to ask questions to people like, how does the intervention feel to you? You know, how much burden did it take to be a part of it? You know, does it clash with your values? The real skill, I think, and where we've been incredibly lucky having Lisa Guccione involved, is how you analyze the data that you generate back to those frameworks and do justice to the robustness of the analysis process against the implementation science domains. But again, lots of tools and resources on the Act Research website that can help with those kinds of things.
Yeah.
So thank you.
I would say that the TFA, just from experience, I found that quite, like you say, very easy to use. The paper, and I have referenced it in the talk, the survey questions that ask kind of give a good flavor about how acceptable, you know, a model of care is or an intervention is, and then they can be explored further in an interview. So certainly from that respect, the TFA, I would say, was quite easy to use.
Yeah, great, thank you. There's one other question that we'll take this as the last one before we sort of tie up. But this is thanks to Neil. This is such an important question, and maybe this is going to be one dear to your heart. What have been some of the biggest challenges in getting this study commenced, so that the trial, the site trial, multi-site trial,
The
commenced?
trial, yeah. So in terms of the feasibility, the first thing to say was that there were no challenges. It was amazing to partner with Bendigo Health. In terms of the trial, and this is a process thing in terms of multi-site governance. So ethics, first there's sponsorship, Peter Mac, before you get ethics, which is fun. But then you've got all of the governance processes across each of the trial sites. And that is a challenge in reality, and each there's supposed to be a streamlined process through ERM, but then some services have got their own platforms that they're beginning to use or they're using, and have different requirements to others. So look, in terms of the governance, that has been a challenge, but I guess that's my main role. So yeah, that's it. It's the process of doing research within health services in Victoria, unfortunately.
Thanks, Maeve. And I think, again, at this sort of opportunity, a point of learning, it's to say to people, and something that, I'd underestimated if you're thinking of putting a grant together with several sites, is allowing yourself at least the best part of the first year, if you've got several sites, to get through that process, which of course not only leads you to think about how long you're going to have to collect data and analyze that data, but also how long your budget's going to last. Because you need amazing people like Maeve and Lisa on board early, so we can get things going and get things developed. But actually, you've built your budget for that period of time to be doing the actual study. So those are the kinds of things I think that practically, you learn as you go along. So thinking about that sort of stuff when you're taking into account that really important question that Tanil posed, what would be the challenges? It is actually thinking, gosh, how much of my budget is going to be used up in the first year before we've even recruited a patient? So a really important question. So thank you.
Yeah.
I just want to share one thing, if I can, that was actually published this morning in the JCO Global Oncology. Let me see if I can just share my screen here. And it is something that is it's about people with pancreatic cancer and the importance of why we need to be thinking about transforming models of care and having equitable access to people, not just with pancreatic cancer. But this really struck me this morning. This is a paper published, as I say, this morning in JCO Global Oncology, looking at early onset pancreatic cancer rates globally. So this is about people diagnosed with pancreatic cancer before the age of 50 years. We are going to see an increase, as we're seeing and very much seeing with young onset colorectal cancer patients here in Australia, Australia having the largest proportion of young onset colorectal cancer patients in the world. We're now seeing across the world, and particularly, of course, in low and middle income countries, the rise of pancreatic cancer amongst people who are younger. And so the reason I put this here is, there are lots of reasons, but I just wanted to pull out this conclusion piece about what they found, the authors are saying here. These findings emphasize the need for primary prevention, access to diagnosis, and equitable healthcare systems. And so I'm just going to stop sharing. But I think one of the things for us that's really driving our motivation and our absolute gratitude for having the opportunity to work with patients and carers through the PANConnect trial is thinking about, how do we do this better? How do we not leave anybody behind? And how do we future-proof a system where, for the people who can have care remotely, safely, equitably, we do that, creating space in our systems for people who can't receive care remotely, or it's not appropriate or safe for them to do that, taking burden not just off the patients and carers, but for our incredibly overburdened, busy health care professional workforce and our health systems. So thank you for the opportunity to talk about the work today. Lisa and Maeve, thank you for presenting, and thank you for being such fantastic colleagues and for driving this work so well. And I would also like to reiterate my thanks to the whole team at Bendigo Health and to all of our partners who've agreed to come on board with the PANConnect trial. So thank you, and I'm going to hand back over to Heather. Thank you very much.
I would like to say thank you to Mai and to Lisa and Maeve. Goodness me, those statistics about pancreatic cancer are really, really frightening. But what a wonderful feeling I'm going away with today, just seeing the immensely rich and satisfying work that you're doing. And I really can absolutely guarantee to our audience that we will be inviting you back to let us know how this randomised trial goes. What a great example of feasibility study leading to a trial, and what a great example of metro and regional services working together. So thank you very, very much. I would like to add that some people may be wondering why we're talking about a trial when we're talking about health services research. Now, you really do need to join us in June the 24th, where we're going to present our next webinar, which is looking at what is health services research and what are clinical trials and where do they converge. So you've really set the scene for that next webinar, and I thank you all very much. Now, I am going to, I was going to share my screen, which had the QR code, but I've actually closed it, and we are running out of time. So you will be sent a link to the evaluation, and I invite you to let us know how you found today's webinar. So once again, thank you very much, everyone, for joining us. And we look forward to meeting again to look at regional health services research. Thank you.